All right, welcome again, everyone. We have our uh, bi-monthly Q&A session with Dr. Simon Wong. Tonight, yeah, so the link here, if you want to register every couple of weeks, this link here gets updated um, every couple of weeks with the latest Zoom link. But tonight we have a special Q&A session as this particular paper that was done at Texas A&M was just released very recently. I think it was last month. Simon, my brother heard about it through Mike Mew, and Mike, was able to share this obviously with his late father, Professor Mew, who passed away a couple of weeks ago. And this is, I think, one of the first papers done on the Biobloc. My brother learnt about the Biobloc methodology, the appliances through Professor John Mew. And you can see here, this is the effects of early Biobloc treatment on hyperdivergent children. So as a way to kind of honor like Professor Mew, we'll cover this. And it was just a good time that, this came just, I think Professor Mew was able to see this. So that was good. Anyway, so let's see where Simon is. I'll just give him a quick call. He should be on his way and during his lunch break. But let me just... Oh, yeah. So if you haven't downloaded already, let me just share that link again. Let's see. Yeah, so you can just share this link in the group chat. And then you can download the whole thesis clicking on it. You can see the 79 page thesis and so on. And let me just see if Simon is, sometimes he might be a few minutes late because he's still seeing patients. It's his lunch break. And let me just give him a quick call. In the meantime, do tell us where you're dialing in from. We had 150 people registered tonight. Still at 40 something now, so there's a few more coming in. Welcome, Abe, Christina, Kevin, Enrico, Australia, welcome.
Hello.
All right, Simon's in the house. Welcome, everyone. All right, Simon, I know it's your lunch break. Let's get into it. So we've got about 50 folks on the line, and others will be watching the recordings. So welcome, everyone, again. Let's get into it. Simon will share his screen. I'll pass it over to Simon. We'll have Q&A session, obviously, a bit later.
So obviously, part of what we're doing today is bringing up the most recent update in the research that has occurred with my treatment cohort in the release of the 2023 thesis that was completed at Texas A&M under the guidance of Professor Peter Bouchang. So one of the residents there for his final master's thesis worked on the patients that I had treated, assessing the cephalometric changes for my use of Biobloc orthotropics. The paper was completed and defended successfully in 2023, but it was held in embargo for the last 18 months and released, or 2 years actually, and released in May, just recently. So the link that is available for it is at the University Oak Trust. And Ken will share that with everyone. But part of that link, there's an abstract, and it's possible to download the thesis as well in a PDF form. And that is then available for everyone and the public to view. Obviously, it's not a peer-reviewed publication, in an orthodontic journal, but Professor Peter Bushang has spent the majority of his career focusing on hyperdivergent children, and he was interested in the method that I use to manage these children, and we've been able to come up with some very favorable metrics to verify the validity of John Mew's orthotropic treatment process. So there's an abstract which I'll briefly go through, and I'll talk a little bit about the paper and show you some of the cases that were part of that cohort. So we evaluated 46 consecutively treated hyperdivergent patients. They're roughly 8 years of age when we started, or when I started treatment of them. We used John Mew's Biobloc orthotropic treatment, and the treatment ran somewhere between 4 to 6 year timeline with the records. We found significant changes in the skeletal growth direction, specifically when compared to a cohort of legacy X-rays of children in the French-Canadian studies in the early 1950s. As a comparison, we found that there was an improvement in reduction of A and B to the magnitude of 7-fold. So I was able to reduce A and B by almost 2 full degrees. We were able to advance begonia and menton, so the chin came forward twice as much as the control children. So somewhere between 2 and 3 millimeters, 2.5 to 3.5 millimeters in my treatment group. And in the SNA relationship, I was able to improve 4-fold increase, so almost 1.5 degrees compared to the controls. We reduce the class 2 molar correction with 4 millimeters, 4.2 millimeters. And most importantly, we were actually able to reduce the vertical growth by 1.5 degrees, whereas the control group had no improvement in their vertical growth. So that outlines what we call a significant change and a skeletal change in the therapy. So that's very favorable to validating posture as a etiology in malocclusion, because Biobloc orthotropics is about controlling posture, and with the assumption that posture is a driving force in the growth pattern. When we control posture and we find a change in skeletal growth pattern, then we know that they're tightly interrelated. Orthodontic treatment to date has never found a system to consistently create favorable skeletal change. So this is one of the few treatments, first treatments, that show promise in controlling vertical growth patterns and improvement in also the chin relationship in A and B reduction. So very, very favorable. Now, if we look at the thesis paper itself, it is available for everyone to download. It's in the form of a traditional university master's thesis, so not in the same format as a journal review, but generally journal papers are derived from master's theses. They're just summarized in a slightly shorter, more concise form, and then submitted to the journals for peer review. So when we look through the papers, it basically talks a little bit about the difficulties that we've always had in managing skeletal malocclusion, in particular hyperdivergent malocclusion. It's one of the occlusions that worsens with time, similar to class 3 relationships. Class 2 relationships often improve if they're forward growth patterns, but hyperdivergent is a situation where the maxilla is pointing in one direction and the mandible is pointing in a separate direction, and as they grow, they get further apart. So it's the most difficult of all malocclusions. When we have a reasonable power in the cohort, 46 is a reasonable number, especially in orthodontic studies, then we have more confidence in the metrics that are measurable. There's a lot of detail about divergence, about traditional treatments that have attempted to manage it with often very little in the way of success. We talk a little bit about the nature of Biobloc orthotropics, what is involved, some of the previous limited research, and we have information about the treatment group and the control group, which is from the human growth and research studies at Montreal University. So legacy historic data. We took x-rays from the French-Canadian cohorts that were studied. The way that we measure it is effectively we do all the cephalometric analysis on my cohort, and we do cephalometric analysis on matched children with similar starting relationships, and then we follow them through that same timeline, and we compare the metrics of my cohort from start to finish, and we compare the natural growth metrics of untreated children within the French-Canadian cohorts, start to finish, and over the same timeline, using the same gender and the same ages. What we did find was there was control of vertical, and there was a marked improvement in the chin relationship. When we look at why that happened, we're trying to figure out what's the mechanism behind this method of treatment. And one of the primary studies that Peter Bouchang has focused his life's work on is postural control and true mandibular rotation. So effectively, we would say that the Biobloc therapy produces significant improvements in AP, maxillomandibular skeletal relationships through anterior mandibular displacement. Biobloc therapy produces significant molar corrections and reduction of overjet. Biobloc therapy changes mandibular growth in a more horizontal direction. Biobloc therapy does not have a negative effect on mandibular divergence, producing slightly greater decreases of the mandibular plane, slightly greater true forward rotation than expected, and Biobloc does not produce significant changes in the hyoid or hyoid angle position. So basically what that says is that we improve the direction of growth in all metrics that we value in orthodontic and orthognathic treatment, but it doesn't seem to improve the hyoid position, which is one of the markers that we look for sleep disorder breathing issues. So basically we're saying that we're getting skeletal changes, but not necessarily any correlation with breathing apparatus. When we look at the tables, we get a sense of the appliances that I used, which is very similar to what I teach in postural orthodontics. We add in John Mew's stage 3 appliances, which is the penalty appliance that enforces closed mouth resting posture. So these are appliances that, if you like, cast the two jaws together so that we force a change in the direction of growth by enforcing a closed position at rest. So postural orthodontics, we expand, which is similar to what we do in orthotropics, but then we rely on exercises to improve the tone and to focus the children into resting with their mouth closed. In orthotropics, we go one step further and we penalize children for hanging their mouths open. So it's the next level, not something that I teach because of too many issues of compliance and issues of dropouts if you have not the skill levels to be good with case selection and management. So postural orthodontics is a simplified version for a lower level of complexity with hyperdivergent patients. And how do we know that they're hyperdivergent? We can basically measure the angle of growth and the level of divergence. So things like y-axis, Frankfurt mandibular plane angles are useful to know. So to give you an example, my cohort y-axis was 71.4 degrees on average, whereas a normal growth pattern is 59 degrees. So it's significantly divergent, so super high angle. I was able to take my children from 71.4 down to 70.5, whereas the control group, which is the natural growing population, who were hyperdivergent, 70.8, unchanged after that 6-year timeline, 4 to 6 year timeline. We were able to improve A and B from 4.9 down to 2.7. So what does that mean? We were able to take these hyperdivergent class 2 patients down to full class 1. The control group went from 4.7 to 4.4. So effectively, we were able to change children who were hyperdivergent and reduce their hyperdivergence and take their class 2 relationship and convert that to full class 1 relationship. Unlike the control group, where they continued to remain within their skeletal relationships from the start to finish. This has significance in the management of orthodontic care for children, because previously we've never been able to show skeletal change on a consistent basis. Skeletal change happens all the time on cases that we treat, but not something that we can consistently say this is going to happen. So this is one of the first large cohorts, so 46 children, where we have consistently reduced vertical growth, which has not been known to happen. And we've been able to convert children from class 2, who are hyperdivergent children who are also class 2, to full class 1 relationships. When we look at the treatment cohort of children who we have treated previously, in this study, I was able to put together some summary images of the treatment cohort. So these are kids who we've been able to look after. We use expansion appliance in the preparatory phase, where we develop width, and we open the bite at the front to enforce a forward tongue position. We then utilize a penalty appliance to enforce a closed mouth resting posture, where the children have only one comfortable position to close their mouth in, and every other position, these acrylic locks rub against the lingual soft tissue. It's managed over a very long time frame. We don't see the skeletal changes until after the 4th year, where most of the changes occurs at the 6-year mark. We were very fortunate in that I was able to develop very significant, noticeable aesthetic changes to facial growth and development. And over that timeline, I was able to show using not only the clinical photography, but the X-ray cephalometric, so that it becomes measurable. The treatment of hyperdivergent children has always been very difficult because that hyperdivergence, unless you use metrics of X-rays, can sometimes be difficult to discern through visual interpretation. So you actually have to measure the divergence and the direction that the chin is growing relative to the direction that the maxilla and the skull is growing. So we know that that trend doesn't normally improve, normally worsens in time. We know that unless we are very vigilant, not only does the divergent increase, but sometimes the class 2, which is very common, can also increase. We know that these children do not fare well, and they're the typical children who end up needing surgical intervention because the bite opens at the front. Now, we do tend to find that in many cases, we don't have dental open bites, but we still have a divergence of jaw relationships. And these are the ones that throw a lot of people out. These are the ones that you're always chasing class 2 with the mechanics, because you seem to improve the dental relationship, and then all of a sudden, the next time you see them 6 weeks later, the class 2 is returned. So you put the elastics on, or the Jasper jumpers, or whatever mechanics that you use, and then you end up with a situation where you almost get to that class 1, and then you see them in the next recall and they're back to class 2 again. That's because their chin is growing into a different direction. And we have the opportunity, because I've been very diligent with my record taking, and because I have followed through these children over a very long time frame, and I've used the technique that we've consistently been able to show that addresses the postural weaknesses behind what we call the etiology of these malocclusions. We've been able to submit this to universities to study, and hopefully to be able to take it on to peer reviews so that the orthodontic community can take note of what is possible. The cohort that I submitted were of over 150 consecutively treated cases. Within that cohort, we had 46. So approximately a third of my cases that I treated with orthotropics were what we call hyperdivergent. So I only treat skeletal malocclusion using orthotropics because there's no real justification when there's a lesser degree of malocclusion. When we have significant malocclusion, we know that very little can be of value to improve the relationship of the jaw growth, and we struggle to get the teeth to line up anyway. But these are cases where we are very much limited to surgical intervention. With orthotropics, we are effectively trying to avoid the need of surgery, and if done using John Muir's principles, very often we can even improve the growth of direction to a degree that we don't even need orthodontic intervention in the teenage years. So it's been a long struggle. This is 15 years worth of work. And over that timeline, the treatment methodology has been refined by myself because of experience, because of the trials and tribulations that I've had to undergo to do a treatment that has, in previous times, not really had any evidence basis for it to be what we would call a valid standard of care approach. So one of the reasons why I don't teach orthotropics is because my wishes for sharing knowledge is to share evidence-based knowledge, share evidence-based treatment. Postural orthodontics, we've shown to have had many similar variations of treatment done over the decades and have been verified through university studies as valid treatment. So my take on that treatment through the modifications and the minor adjustments that form postural orthodontics has been something that I have been very happy to share. In orthotropics, I've been able to share the outcomes of my treatments, but I've limited the teaching of this process because it can be challenged and found wanting. So one of the purposes that I've been trying to achieve over the years is to validate John Muir's treatment by treating and recording my treatments and submitting it for independent verification at as many universities as I can who are interested. So this cohort was treated by myself, and this cohort was independently verified at Texas A&M. We also have a class 2 cohort that's being independently verified at Alberta University, and we're about to hopefully submit a new paper, a new thesis that was completed last year for journal review as well. When we have more of the universities who are willing to look at my work, then we have a greater chance of being able to get theses defended successfully that show favor to the hypothesis that there is validity in the link between posture as the etiological cause of malocclusion. And in doing so, we'll be able to share with our community metrics that support this and thus becoming evidence-based treatment into the future. And at that point, I will be more than happy to start teaching and sharing my knowledge about orthotropics. So this treatment cohort has been undertaken over 15-year timeline, different starts, different finishes. We have been able to follow these children over, in some cases, over a decade, because the nature of my practice allows me to maintain strong relationships because we spend a lot of time, many years together, and because the outcomes are very often so favorable, when we ask the families to bring their children back in for long-term reviews, they do so. That has given me the opportunity to be able to monitor and evaluate the long-term outcomes of non-fixed braces, removable appliances using John Muir's orthotropic methodology. So we found that not only have I been able to make skeletal changes, but more often than not, I've been able to improve the dental relationship well enough that many of these children don't move on to fixed braces or aligners in the future, although some cases, of course, when we have significant imbalances to begin with, we don't end up with a situation that has a picture perfect finish point. When we do follow the process that John Mew has outlined and the families comply, then we end up with significant improvement even in syndromic children. Right? So some of these cohort children that I've treated have syndromes who theoretically cannot grow correctly. And very fortunately, we've been able to make changes in those children so that we've been able to get a normalized outcome. When we take non-syndromic children who follow the instructions, we get enormous change. We get enormous changes that sometimes are very difficult to explain in the understanding that we have of normal growth and development. So I've been very fortunate that the various heads of departments of the universities have been willing to explore my cohort of treatment, the data set that I've shared, and they've assigned their residents projects to investigate the records that I submitted, and hopefully the future for our profession will shift in a way that is going to help our communities, children, grow in the way that we really should. We have too long relied on our profession to align teeth to become straight, as opposed to considering what the true root cause of malocclusion is and address them so that we not only can improve the growth pattern, but where we can also help parents understand about prevention, right? If we understand the root cause of a disease, then we can actually prevent it from developing. So with correct diagnosis, correct treatment planning can be made, and then the goals can be significantly broader than if we're just guessing at what's causing issues and trying to hide the symptoms that we don't like. When we move into a medical mindset of treating a disease as opposed to treating a genetic disorder, right? So historically, we've always viewed, because we can't change skeletal growth, and we've never been successful to date on a consistent basis, we just assume that it must be a genetic predisposition. When we can change the outcome of growth, then we have to accept that there is an environmental etiological factor. When there's an environmental etiological factor, then it's something that we can correct and something that we can prevent. And that gives us enormous influence in the growth and development of our children. And so this is something that I've been working very hard under the guidance of John Mew, Mike Mew, Bill Hang over the early years, and then through my own interpretations of what good growth is, what posture is bad, what posture can change the growth pattern, and what changes in posture can improve wayward growth. We know that if we don't verify what we believe, then it's just anecdotal. There's no validity to our claims. And we can't work in a situation where we don't validate and verify what we claim we can do through independent research, right? Not just what we see and what we measure, but what other people see and what other people measure, right? so that we can stand as scientists and not just clinicians who are robots following a prescription. We want to be in a situation where we recognize issues for what they are, where we diagnose the true root causes and we address those true root causes. And the only way to do that is not to follow blindly, but to question the things that we see and to measure and to record and to have independent reviews, right? Peer reviews, so that what we see is also confirmed to be true by other experts and other specialists. When that happens, then we can stand proud and say, hey, this is real, let's share it. One of the things that has brought you to me is that you've been open to the idea that real change is possible when using the correct techniques. These records that I've kept, these records that I have taken and kept and shared have allowed me to pique the interest of you and pique the interest of the university heads. And that's all I've ever wanted to do, to be able to show what I believe to be true and what I see in my practice to be evident, to be the truth, to have a real place in our profession. I've been very fortunate that I was taught by John Mew, who passed just recently. Because he lived to almost 97, I was, despite the age gap, still able to learn enormous amounts of what he taught and his wisdom of his life experience. And I've taken his work, I have utilized it to help the communities that I live in, and I've documented it, and now I'm sharing it with our communities, our profession, so that we can take this valuable information and to use it in our practices and to provide our profession a better understanding of the malocclusions that we treat, so that we get outcomes that are more favorable for the children that we look after. Ultimately, this is the most important thing, that we're trying to help children who have issues, who come in to get their teeth straight, but up until now, we've never really understood why their teeth are crooked in the first place, other than a blanket, oh, it's just, you're born that way. One of the things that I'm hoping to do with this research is to show that there is truth in the link between posture and malocclusion. And if we control posture well, we can make a significant change to help growth and development, and hopefully will also improve the general health and balance of our children, so that in their adulthood, they don't suffer some of the ailments that are intertwined with poor jaw relationships.
Hey, Simon, I know you're going to wrap up soon, but do you have any time for Q&A, or are we going to leave that for another session?
Sure. Let's
How much time do you have? I know it's your lunchtime. Do you have another 10 minutes?
I've got 5 minutes, and then let's see.
So I've updated, yeah, so there's some questions. Just hit refresh, please, because a few questions came in. Yeah, there we go. as mentioned, we're on every 2 weeks, so we didn't have enough time to also go through a lot of questions. But we'll be back same time, same place, uh, next in 2 weeks' time, so you can ask questions in relation to the presentation tonight on the paper. Once you get a chance to read through it, I'm sure you have a lot more questions. All right, Simon.
Okay, so we've got some questions that aren't related to the paper, but we can still answer those. Can we follow semi-rapid expansion in normal hyrax and normal lower expander with a jack screw, as we don't have the expertise to make a Biobloc right now? I don't know. I don't really know. The system that I've created is for the appliances that I use, and I couldn't really say, because I've never tried, using the rate of expansion with different appliances. There is research to show that people have used semi-rapid expansion for other appliances in the maxilla, including fixed appliances. But it's very, very difficult to do a half turn in a fixed palatal expander. So how do you make sure that the parents follow the direction of that relationship? So it's very hard for me to be able to give you an outcome, other than the fact that you're welcome to experiment, but I have no experience. Next question is, how do you deal with 10 plus millimeter overestimating in class 2 division cases where usually twin blocks can be given to bring the mandible forward? Can Biobloc have that feature? So when we have significant skeletal over jets, such as in class 2 division 1, then I use orthotropics. So this is the research that I've submitted for validation at the universities. Significant skeletal malocclusion is very difficult to correct using any other method. So Biobloc orthotropics can correct significant skeletal malocclusion in children of an appropriate age, but postural orthodontics, it's outside of the capacity for consistent outcomes. Also, how can we open deep bites and bring mandible forward in class 2 division 2 patients? So very often the deep bite relationship is over eruption. So you've just got to control the incisor position. So you've got to flare the retroclined incisors forward into a more proclined relationship. You can either use the Biobloc appliances, or you can use fixed braces, right? Limited fixed braces to intrude the upper incisors. Then if you improve their posture and stop them from resting with their tongue between their molars, then division 2 patients generally grow forward because they have a tendency for forward growth in the y-axis anyway. Next question is there any chart of intermolar width according to ages so that we can compare what we need to expand or not? So 4.5-year-old has intermolar width 31 and minor spacing. How do we attain 38 as the mature? So intermolar width is fixed on completion of the molars socking in. So 6-year-old molars, when they sock in at 7 years of age, that intermolar width does not increase much more than 1.5 millimeters. So whatever the intermolar width is at 7 is the kind of like the final intermolar width patient. So if they come in at 31 millimeters at 7, they're going to get to 32.5 mils by the time they're 13, which will mean that they're deficient by 6.5 mils. The primary second molars are usually 3 mils less than the permanent molars. So if a 4-year-old comes in and their intermolar width is less than 35 millimeters, then they're going to be crowded. and it's not going to get any wider on its own. Intermolar widths are usually set. When the molars come through, they lock in and that's it. Do you do Jefferson analysis for your cases? No, I don't. There's many different systems available. I've used Jefferson in the past, but I don't use it at the moment, no. When you unintentionally end up in a scissors bite because the upper was being expanded, but the patient didn't have a lower appliance yet or couldn't wear the lower, how can you handle this situation? So I don't end up with a scissors bite unintentionally because I don't do unilateral expansion other than obviously in a perfect lower arch like a low angle class 3. So I don't end up in that situation because I monitor what I do. People who end up in a scissors bite are basically expanding without any thought. So the way to avoid it is to not do it. You don't do it if you understand what you're doing. If you get yourself into that situation, then you're out of control. And if you're out of control, then effectively you're working outside of your skill set. If the upper expansion is not completed yet and we're not completed with the upper appliance, would you stop turning upper for a while, introduce a lower expander, continue expanding until it'll catch up? Yeah, sure. So if your upper is wider than the lower, and you have the ability to develop lower arch expansion, then obviously you want to kind of unify the two. So absolutely. How you get out of the scissors bite is by expanding the lower arch. Conversely, if you're completely expanding upper and the ears still have 6 months of life, would you make a retainer of the rest on the upper sixes to intrude palatal cusps as needed while continuing to expand the lower to the palatal cusps of the sixes are aligned properly? So that sounds like a good plan too, yeah? So you've just got to control, you've just got to coordinate. So like so long as you are able to re-coordinate things, then you're not out of control, just out of step. Next question is, if you're done expanding the upper and have slightly expanded and the ears are about to exfoliate, would you stop using the upper appliance, cold turkey, and just use the low expander until the sixes are better aligned? Well, when your anchorage teeth fall out, then you've got nothing else to hang on to. You can consider using a changeover appliance to maintain that development. The upper ears usually fall out before the lower ears, so you've got a bit of time to catch up with the lower. If you've overexpanded, you can let it all go and let it relapse a little bit, but it just depends. If you have a scissors bite, you will not have relapse because the bite is locked into that relationship. Okay, and I think that's all I have time for.
Okay, thanks, Simon. We'll continue with these questions that have been submitted. Sorry, we didn't have the usual time, but I'll let Simon head off back and have his 5 minutes of lunch before he gets back to work. Thank you, Simon.
Thank you.
Well done. And yeah, so I'll just say goodbye to everyone. Just a quick announcement. We do have another 2-day event. It's the first time we're doing it twice in a year. So I thought I'd make the announcement right at the very end for those of you who stayed behind. You can see the link that I thank you, Linda, for your kind words. But for those of you who are new to Postural Orthodontics, we have our 7th 2-day event coming up in November. It's about 4 months away. We have a number of guest speakers. Kevin Boyd will be joining us live via the live stream. This will be all on Zoom, so you can join anywhere around the world. As a special, we've decided to give the recordings from last year's event, which was held in September 2024 in New Jersey at the Hilton DoubleTree. We had Dr. Amanda Wilson, Professor Narinder Singh, Enrico was there as well. Big shout out to Enrico, founder of 8 Point Dental Lab, who's been working very closely with Simon for about 20 years to perfect these different appliances. that have been based off of Professor Mew's work with Biobloc and modification of the Schwartz appliance for the lower removable appliance. So anyway, so yeah, so as a free bonus, you get not only the recordings of the event in November if you miss some of it via the live stream, or if you want to get started straight away, you can watch the 2-day recordings from last year's 2-day event. Similar curriculum. You can see what is covered in a detailed, page here, /tickets. Day 1, day 2. It starts around 3 o'clock Eastern on a Friday, finishes around 10 Eastern, and then Saturday as well. All right, so it should be reasonably favorable depending which time zone you're living in. But yeah, so you can check out all the really good specials we have right now during the super early bird. And if you're in different countries, do reach out. We can give a small additional discount off these already very discounted prices. So that's the next upcoming event. As Simon mentioned, this is postural orthodontics, and the reason why he's not teaching the orthotropic, the more how to treat the more severe cases. As you heard, it could be taking up to year 4 and 5 and 6 before you see these amazing results that you saw. And we've actually published them here as well. You can see the before and after of these 100 plus consecutively treated cases. So that's there. It's besides the 2-day intro. There's mentoring as well, where you can have your cases submitted to Simon. He will supervise them through the that 12 to 18-month period for these milder malocclusions, right? If you were to present a severe case that needs orthotropic type of appliances like the Biobloc stage 3 that he mentioned, that could take 4, 5, 6 years to treat. And unless you're willing to be mentored for 6 years, that's why we've decided just to focus on the mild to moderate. That typically takes 12 to 18 months of work, and thus case supervision as well if you really need or want it. So the 2-day intro is, as I said, an introduction to not only learning how to deploy these upper and lower removable appliances, but also to deploy GOPEX, good oral posture exercises that Simon released, I think it was about 10 years ago with Sandra Khan, who helped publish and co-author this book that is freely available. You can get a free copy. You can email us if you would like a copy, info@straight teeth naturally. But yes, if you're interested in joining us in November, and you can watch the recordings from last year straight away, you don't have to wait necessarily for the November live stream. You can always get started straight away with the recordings from last year. It also comes with very detailed notes on how to use the Biobloc appliance for the upper, hundreds and hundreds of pages of extra protocols. And so it's not just here's 14 hours of content. There's very, very detailed notes, protocols, and templates. And you can join this wonderful community. There's about 500 dentists who've already gone through this program over the last 5 or 6 years, and they're there to support you on in this journey as well. All right. So if you have any questions, I'll open it up to questions now for those interested in attending this event in November. If anyone has any questions, feel free to type it in now. I know it's quite late for those of you in the East Coast like myself. It's around 11 p.m. But if there's any questions, feel free to send us an email, info@straightteethnaturally.com. Once again, if you joined us a little bit late, here's the link to the paper that was recently released in May, June, on roughly 50 cases from Simon on treating hyperdivergent children. These are the very severe ones. So that's about it for tonight. We'll be back Where do you register for the event in 2 weeks? Every 2 weeks, we run these free Q&A sessions. And sometimes we have guest speakers. Sometimes we have a special presentation like we have. You simply go to this link here, straighttonatural.com/ask-dr-Wong. In a few hours by tomorrow, the link there will have the updated Zoom link for the next event, which will be in 2 weeks. Free Q&A session for about 45 minutes to an hour. On that note, thanks for joining us. Take care and have a great evening. Bye, everyone. Thanks, Stovall. Good night. Good morning to you in Lithuania. Thank you, Margarita. Stovall loves the sunset. All right. Thank you all for joining. Good night.